With somewhat delayed schedule, so I would like to start this session. This session is a Mitral TEER live demonstration with the 2 lectures. I'm Jung-Sun from Severance Hospital University, South Korea. My co-chair is Vinayak from US. And I would like to introduce our panelists, Simon Lam from Hong Kong, Ching-Wei Lee, and Yung-Tsai Lee, Takeshi Matsumoto, Takao Morikawa, Toru Nagamura, Shinichi Shirai. So we'll start first live demonstration. Dr. Kang, can you hear me? Please introduce your case.
Yeah. Thank you. I'm Professor Jung-Sun Kim. I'm Dr. Do-Yoon Kang, and our team is ready now. This is Asan Medical Center. Let me introduce my team before the case briefing. The Hansu Park, our senior interventional fellow, and Professor Dae-Hee, the head of the imaging team, and our senior imaging fellow, So-Min Lim, is attending for the imaging. And Professor Han, our anesthesiologist, is keeping the patient's vital signs. And Dr. Park, can you please show the case?
Yes, thank you. This case is 78 years old male, admitted for worsening dyspnea, NIH functional class 3. He had a history of heart failure with mildly reduced ejection fraction and atrial fibrillation. He had been guideline-directed medical treatment for heart failure and atrial fibrillation. The echocardiography showed severe mitral regurgitation with replaced tethering due to the enlarged left atrium. Next. His STS score for MVR was 6.1. Next. During the admission, we did fully volume control, about more than 10 kilograms of the body weight reduction. Next. Chest PA showed no significant pulmonary edema. Next. EKG showed atrial fibrillation. Next. Coronary angiography showed large left atrial volume and severe stenosis of the left coronary artery. Next. Coronary angiogram showed no significant coronary disease. Next.
The patient is admitted for heart failure and on the hospitalization over 3 weeks. And Professor Dae-Kim is taking care of the patient, and he will brief more about the patient with the echo images.
Yeah, next. In number 1 image shows the parasternal long axis. The left ventricle is dilated. The dimension was 50 over 66 millimeter. Left atrium AP dimension was 71 millimeter. You can clearly see tether the posterior leaflet in number 1 image. In number 2 image, you can clearly see the eccentric severe MR jet from the coaptation defect. And number 3 image shows showed axis image as some mitral annulus calcification are present, but it's not a big deal. Corresponding image number 4 shows the regurgitation from the whole coaptation line. Next. In apical view, the array volume index was 144 and 54 millimeter per meter square meter. The mechanism of MR, although the left ventricle is dilated, the anterior leaflet is not tethered. Usually, the main cause of mitral regurgitation mechanism is arterial functional MR. You can clearly see severe mitral regurgitation death in 3, 4, 2 chamber images. Next. Transexual echo image shows diffuse coaptation regurgitation death from the number 2 image. Number 3 image shows the 3D unboxed view color, and then number 4 is corresponding color flow image. You can some coaptation defect from the central medial region. We planned to implant at least 2 clips. Next. The mitral vein area measured by 3D was 7.8, and the length of a posterior leaflet was almost 2 centimeters. And you can clearly see flow reversal in left upper and left lower and right upper pulmonary base. Next. After massive volume reduction, we can clearly identify the persistent severe MR in this patient. Thank you.
Yes, the patient is the atrial functional MR patient, and coronary was okay. And now he is on the IV diuretics and more than the 40 milligram, 80 milligram Lasix per day. And still, he has the NIH class 3 dyspnea and could not be discharged. That's why we planned the TEER procedure after 3 weeks of the hospitalization. Do you have any comments or questions for this patient?
We have lots of expertise
Yeah.
as a panelist. Is there any comments or question? Especially type of some clips, any other some tricks?
Yes, Dr. Kang, this is Williams from Taiwan. And
Yeah.
yes, I think the imagery is pretty nicely demonstrated, and the leaflet length is good enough. You also mentioned the location you want to grasp the leaflet. There is some mitral annulus calcification. So is that will impact on your clip choice?
Yes. Can you please show the 2D images, Kim? Yeah.
Yeah, this is a live image. But let me show some image acquired today. The degree of MR slightly decreased from the last image. Yeah, coaptation gap is not so big.
You can find the calcification as Dr. Lee said. Yeah.
But right now.
But
okay.
that I think that we can avoid.
That's not a big
the
deal.
region,
Yeah. Because the length is good enough.
And also whether we want to aggressive is our central lateral region, that maybe we can we can avoid the calcification there. Yeah. Because that is not the target, and the more lateral region, there is no calcification. So that's why we selected the central lateral region for the first target. And actually, we selected the bigger clip because the calcium length is enough, more than 2 centimeters, and the lumen is the mitral valve area is large enough. What I want to ask the panelists is that your experience with the atrial functional MR.
So
Actually, this is not indicated in the US or European guideline, and there's very small data from Europe and Japan. But many of our operators have their experience, and I want to share the experience.
So do you choose XW in this
Yeah,
case at first?
we chose XTW.
Are you all agree? Yeah, to this one?
So can I make a question? Another question? So I'm Takao from Japan.
Oh yeah. Takao.
Yeah, I'm curious. How is this patient tricuspid regurgitation in
mild
case
to moderate.
mild to moderate? Okay, that's good. Sounds good. Yeah. In such case, concomitant TR should be issue, but it's okay, I think.
Very good point. And those patients with a severe TR, do you select the mitral clip and subsequent track clip, or send the patient to surgery for DVR or MVR TAP? Actually, we are routine practice for those patients.
Dr. Kang, can you proceed?
Oh, yeah.
Because we have some limited time.
Okay, yeah, we have limited time. And we have did the puncture. Because the area was huge, there was some difficulty in select the good puncture position. And with I used the SL1 and BB needle, with the large shaping of the needle, we could find the good septal puncture position. And because the septum was a little bit thick, so I used the electrocautery device for the septal puncture. And
So
this is
where is the position of septal puncture?
Oh yeah,
So
can you
it's
please
a
show the
posterior-
septal puncture position?
Yeah, inferior posterior.
Yeah.
We
Why
tried.
I progress?
The height of the
Talk me
initial
about that.
maximum posterior superior puncture site provide 6 centimeter puncture height. After that, we tried 5 centimeter, and then 4.3 centimeter, and 4.2, 5.1. We tried several times.
Yeah, can you please show those 3D
Final
images?
was 4.3 centimeter. And the puncture location is slightly posterior from the commissure.
Okay, I will progress. Dr. Kim, please, can you please show the
Yeah.
device? Yeah, okay. Now clip is coming out. We'll show the tip. Yeah. Okay.
Yes, regarding to the clip choice, I think you can either treat it with the NTW or the XTW, but the most important thing is you will not treat the atrial secondary MR with XT alone. Because you use a narrow clip arm, you would put a lot of tension to the leaflet and may cause some tear.
Okay, yeah.
Yes, I totally
That's a
agree.
very good point. Yeah.
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 I agree with you.
Movement from,
I agree with you because the huge LA sometimes very difficult to visualize the hidden or difficult to visualize the chord in the as you can see so there is a wide chord free zone, but the sometimes interfere the insertion and the good grip grasping in XTW sometimes. So maybe we recently used the XT first.
yeah, Dr. Kang,
Yeah,
position is good.
Yeah.
Looks good.
Where is our first target point? Can you please show the
Yeah, right here.
Doppler?
Yeah.
Okay. This
That's
is
the
this
first
would be our
point
target.
we are trying.
Yeah. And I will check the trajectory. A little bit M dive. Yeah.
Yeah.
Oh, this still M dive.
So, Dr. Kang, may I ask about the patient hemodynamics? Because if the patient have low blood pressure, so the MR could be less.
Yeah. Now the patient's blood pressure is 108 and 66, and heart rate is 100.
Yeah.
And now
One more
quite
try
stable.
here.
Yeah.
Yeah. The trajectory is good. Slightly posterior.
Yeah, it's moving slightly posterior. How about this? Here. Is it too central?
Oh, okay. No
Too
problem.
much M dive?
No
What
and
do you think?
dive.
Dr.
Okay.
Kang, what was the LA pressure?
LA pressure when we did the first puncture, it was not quite high because
After
the patient-
maximal IV diuretics treatment.
then also patient received the high dose IV diuretics just before the procedure, and the peak was 15.
Still display.
Yeah.
Functional class 3.
Yes, I think Dr. Kang did a very good job. It's very important to optimize the patient before they bring them on the table. Because
Slightly M-dive.
the gap may be
M dive.
much larger and made the MTA procedure become more complicated. So optimize the patient. I think it's a very good
Oh, that's
job.
okay.
Do you like this angle?
Yeah.
Okay. Then we'll keep this angle and we'll check the grip pulse.
Open the clip.
And I open the clip.
Yeah, too much rotated.
And when treating the atrial functional MR, it's always difficult that the anterior leaflet is flat and posterior leaflet is the tethered, and make a good. And also, as you can see in the image, the area is big, so mitral clip is far away.
Counterclockwise rotation, please.
So
A little bit.
clip loops moving medial and lateral, synchronizing with
Clockwise, please.
respirator.
Clockwise, please.
So,
Okay.
sorry, my question is, how is tidal volume now?
tidal volume?
Yeah.
tidal
quick
volume.
looks
마츠코님
moving.
타이다 볼륨 얼마죠
medial.
지금? 380? 480 타이다 볼륨.
Sorry?
480.
480
yeah.
now. Yeah.
Okay, check the gripper.
We'll check the gripper.
Yeah, both down
Clearly seen.
and posterior.
Okay, then I'll try get in.
It looks like a little bit out of her.
Yeah, I agree. Yeah, but
Do you apply plus knob or just?
I didn't apply, but I will try in this angle, and if it doesn't work, I will try more without the knob change. 여기서 들어가면 될까요? Do
괜찮을
you
것
like
같아요.
this region?
Yeah.
It's into L dive, isn't it?
No. No L dive.
Okay, imaging is not stable now. I'll wait. Okay.
Slight L dive. Yeah, in this view.
Okay. Then I will give some more M knob and we'll check again.
So,
Try to
Dr. Kang,
clear,
where is the exact target? Because during the
central
presentation,
region.
the maximal
Yeah.
PISA was from the
Maximum PISA.
PISA
Center
is
to
similar
medial position.
for the entire coaptation defect. So we tried to evenly divide by from the exact central region, central lateral and central medial.
Yeah, the central lateral is the target.
First target.
네. 컬러 한 번만 보여주세요. 컬러.
거기 맞아요. 거기서 하면
Here
될
is
것
the
같아요.
target.
target.
Okay. And I will check the 3D 양판세 view again. 한번 다시 보여주세요. 좀 돌아갔습니다. Okay. It's
돌아갔네.
rotated.
지금 괜찮은 것 같아요.
Do you like this?
Okay.
Okay.
오케이, 다시 들어가 보죠.
Check the grip again. And
First here.
we'll proceed.
Trajectory is good. Okay.
Can you see the posterior flap?
Like this. Let's check 3D.
Still puncture height is a little bit high. So
Yeah, clockwise rotation, please.
Yes, in Asia Pacific region, often we may encounter the small anatomy, small left atrium, but this is actually you can apply some maneuver to overcome the loss of height. But for the
okay.
atrial
Yeah,
functional MR, I think that this is the most challenging anatomy,
that's right.
not only for the imager but also for the implanter.
Yeah.
Usually we'll puncture at maybe more inferior to get to lower height. Yeah.
여기 괜찮은 것 같은데.
I got the anterior flap and posterior flap now.
Almost there.
But isn't it 2M dive?
Yeah, M dive.
위치 한번 좀 봐주세요. 선생님.
돌아간 것
돌아갔습니다.
같은데?
It's rotated. Yeah.
It may be rotated. Yeah.
Yes. There's some overshoot to the clockwise rotation. And I will gently move a little bit rotated counterclockwise.
Yeah, counterclockwise.
Some more.
Okay.
Okay. Can you please evaluate again? Yeah. It's central now. Can you please show the color?
Yeah, right over there. First
Yeah.
clip. Target.
Then do you like this position or move to more lateral or just keep here?
Please keep here.
Yeah.
I think
how's
this
the
location is
Panelist?
good.
Yeah.
I think
And
this location is good.
can you please visualize the posterior and anterior leaf flap? Whether it's well captured?
Yeah.
Yeah, please use the. Can you please use the zoom imaging because in atrial function MR, yeah.
Let's take a 3D ampacid view one more.
And this kind of the atrial function MR, we always have some worries, some about that the clip gives too much tension and has some possibility of the tear of the leaflet.
Yeah, the rotation,
Yeah.
orientation is good. Looks good.
Okay, so I will gently grasp the clip without too much tension. Yeah. 이 정도 잡을까요?
괜찮을 것
Okay,
같은데.
okay,
네.
You like
Looks
it?
good.
Yeah. Clip down.
Look down.
Okay.
Posterior. Yeah, the both. Yeah.
Can you visualize the both
Anterior.
leaflet?
Yeah. Posterior is good. Anterior is not in the gripper.
다시 한번 볼게요.
Yeah. 안티리어가 제대로 캡처 안 됐네.
거기 줌 한 번만 해주십시오.
네.
안테리어. 지금 들어간 거 아닌가요?
Outside the gripper anterior.
It's okay. Anterior reflex coming down. Is it in or out?
들어간 것 같은데?
It's in.
그죠?
It's
Yeah, in.
I believe it's in.
Yeah, posterior insertion
Yeah.
is very good.
And the clip is 120 degree.
Yeah, good.
Can you please evaluate the color and stability of the clip? Yeah.
The problem is anterior insertion is not good
Yeah.
for me.
To grasp more
Oh,
or
yeah, that's good.
Yeah.
Yeah.
then I will
Now
a
it's
little bit
good.
close
Yeah. Okay.
to 900 degree. How about the function now?
Okay, let's take color.
Yeah. Okay.
Just one clip is enough.
If the grasping of the leaflet is good and stable, then I will close more.
Yeah.
Okay,
Let's try.
if you agree. Yeah. Down level down and slowly close the clip.
Oh,
Yeah, the clip is fully closed now.
insertion is very good.
Okay. And tension was a little bit released. Yeah.
Yeah.
The blood pressure is stable and heart rate is 110. No,
Yeah, let's
no
check a
big
pulmonary
change.
flow.
Yeah. And you can see a little bit increase in the sag in the left
Left upper
atrium.
please. Totally. Live update. Okay, go over there.
Almost exactly A to P2, is it?
Yeah.
I think
Yeah.
that
That's
needs to
right.
be targeted somewhat lateral
Freeze.
position,
Yeah,
but
actually
it's grasping
you're right.
somewhat
Yeah.
just central position.
The systolic flow has appeared again.
I think that it would be, it can be good enough if it works very well. But what during
Here.
for the procedure for atrial functional MR, what we worry is that the increase of the tension by the volume and the development of the area enlargement and the long-term outcome of the patient. And I think that the Matsumoto and Jung-Sun Kim has high experience about the atrial functional MR TEER. Can you please share your experience and long-term outcome of those patients?
Yes. So it's atrial functional is challenging for mitral TEER, and especially in this case. So when you gave diuretics before
Yeah.
procedure, the
Yeah.
theater is very wide. It's coming from all A to P2, but after 10 kilogram reduced the body weight, it's a little bit small jet. But so I mean, if for when we think long-term follow-up, I feel we should deploy two clips for
clips.
to close 4A to B2 region.
Transmitral beam.
Then you mean to
We are taking transmitral
What
beam
would you
pressure.
Yes,
recommend
actually we
for the
can see
second clip?
residual jet in medial side,
Yeah.
medial
Yeah.
T2 clip.
Okay. Then you do recommend XT or
Yeah, we are measuring
Anti?
beam pressure gradient.
pressure gradient would be low. Yeah,
Maybe
it's
four,
Yeah.
4 or 5 in the middle, maybe. Yeah, not so
Intermediate,
small.
yeah. So I think I agree with
Yeah.
his opinion because usually increase MR
Yeah,
after the
absolutely.
procedure, especially atrial functional MR. So I think you list the
You can
device
clearly
and
see
then
development
check
of
that
stack.
again.
Okay. Deploy 할까요?
Deploy. Let me check again the
Okay.
insertion of the insertion is very good.
Okay, clip is stable.
Yeah.
So if you
Yeah,
want to
yeah,
put
let's
in
deploy
additional
the
clip, do
clip.
you want this clip in this position? Or so first, why I want to check residual jet in medial side. And I think we should consider the location of this fast grip to move to a little bit medial side and place additional grip into lateral side, or just move to medial side and if MR gone, then it's maybe one grip procedure.
컬러 한번 다시 한번 볼 수
It's
있어요?
now the
굉장히
gradient is
좋네.
already 4, but we don't
Do you
know whether
agree?
it's contributed by the MR itself. So we'll try to see if
So
we can move a
leads
little
or
bit
just,
towards, for example, lateral, and then the pressure
change
gradient may allow an additional clip at the side. Otherwise, the two side you have
Yes.
jets, then they don't know where to put the clip, and the clip may generate further
Yes,
gradients.
the gradient is now, its mean gradient is 4, but the baseline
let's deploy.
mitral valve orifice area is 7.8. So it seems like I feel it's overestimate. So in this case, I always measure area of mitral valve in both sides. Sometimes there is
Okay.
discrepancy area and gradient.
We discussed a lot, and actually after
already
the
released.
actually after the grasping full closure of the clip especially in the atrial functional MR,
Yeah.
I
Dr.
really
Kang?
do not want to
Dr.
deploy.
Kang, there is also
Yeah.
some suggestion
No.
What?
for the position of clipping.
Yeah.
But you already released.
But this, I will explain that.
They are going to
Actually, especially with the atrial functional MR, after full close, I really hate or avoid to grasp again, because the tension is high and the reflex is very weak, and there are several events of the reflex tear or some reflex damage. So what we plan is to minimize the grasping, especially in the atrial functional MR patient.
So the question for panels and chairs, for example, for LV impairment with functional MR, we try to work hard on the LV by medications to shrink the LV size. But for atrial functional MR, likely the atrial will continue to enlarge. Well, we can try to do some more on the AF, for example, abrasions, but usually it doesn't help a lot. And when this patient come back, they only get worse. We don't give improvement further in terms of the residual MR. So in your cohort, so is it the similar phenomenon or any additional thing you will do for the patient? Because underlying etiology is still atrial fibrillation.
Yeah, actually, I understand what you say, and in our cohort, it's still small. However, there's no big difference between the VFMR and AFMR. Still, there's difference in the medication for heart failure of the LV ejection fraction depressed, like Entresto, but otherwise, there's no big difference. 제거할게요.
deploy
Okay, I'll deploy. 컬러 한번 보여주십시오.
컬러
Okay.
줌.
Okay, I will deploy. I deployed.
Already, yeah, very
Save.
stable.
Flow save.
But the degree of MR slightly increased after
Yeah.
deployment. We have to place one more clip medial side.
Yeah, I totally agree with the
Yeah.
games and
Which clip?
Matsumoto's opinion.
XT.
Can you please show me the images more?
Yeah.
And we want to ask the panelists about which second clip would be better. Which clip would be better for second?
So is there any question? Any suggestion?
I
XT?
think usually we will choose the narrow and the short one because it's a very easy to get close to the
Yeah, XT.
and a very easy to
NT.
NT.
Is there any agree?
yes.
So that's NT.
XT?
XTW.
XT.
XW?
Because there is a
Still the
enough
same
basis
Yeah.
and
All different, all
Suggestion.
different opinions.
my motto is bigger is better.
Actually, me too.
Dr. Kang, what do you think about it?
So
Can you?
can you
yeah.
can you check the pressure?
Yes, I will check.
Yeah,
I'm checking
yeah.
the pressure.
And then MDPG as well.
If V wave is gone, still the pressure itself is about 15, 13 in pressure gradient, in pressure. And V wave is, we cannot see the V wave. But as the panelist said, and for clip stability and minimizing the regurgitation at medial side.
2.
Yeah,
Oh.
and I want to add
I
one
think
more
the next
clip.
one maybe 3. In average, it's 2.5.
Can you please show the 2D images of the next target?
When considering the second clip, you should be careful is the location of the residual jet. It looks like from the indentation. If it is only from indentation, the procedure become little tough sometimes.
Yeah.
But if the pizza is right next to the clip, you can do it.
Yeah. So what we target is that just next to the just medial clip, or more stabilizing the clip for the long-term durability.
How about XT?
Yeah. Okay. Then, because still we have the low pressure gradient, and for the more stability with a large aggressive, I will choose XT. Okay. And can you please give us some time to prepare the second clip? Maybe there are 2 lectures, and we will come back. We will come back
that's
soon,
right. Yeah.
just after the preparing the
So
clip.
I think you had better prepare another clip, and then we will come back after 2 lectures.
Yeah, we'll come back soon.
그래, XT 준비합시다.
So let me introduce the first lecture. Is Ching-Wei Lee, a Taipei Veterans General Hospital, Taiwan. How to get proper imaging for mitral TEER procedure, what I have learned. Dr. Lee, please.
Dear Chairman, ladies and gentlemen, and it's my great pleasure to be here. And so this is my disclosure. And then actually, another important disclosure is that in recent years, I have served as both imager and implanter for the MTA procedure. When the image is good and the procedure is smooth and everyone is happy. But when the image is bad, there are some conflicting character to play the different role. So before my talk, I have to confess that in the past year, I used this beautiful, lovely image to do a lecture, so that's why I'm here. But actually, in real life, this terrible T image was also done by myself. So actually, when we have a difficult imaging to optimize the image, I think the responsibility is not only belong to the imager, but also for the implanter. So they should work together to solve the problem together. So my first part will be how to get the proper imaging with manipulation of the transesophageal echocardiographic probe. As we know that by rotating the cutting plane of the transesophageal echocardiography, you will cut the mitral valve in different plane with 4-chamber and bicommissure and LV upper tract view. And we also know that if we are trying to treat the medial lesion, the coaptation line should be like 30 to 50 degrees. If we are treating lateral commissure, we should increase the angle to 17 to 90 degrees. Except for the rotation of the transesophageal angle, we can also manipulate the probe. So imagine that if we rotate the probe counterclockwise rotation, actually we are seeing the left side of the heart and posterior part of the heart. If we do a clockwise rotation of the T probe, actually we are seeing the anterior part and right side of the structure. As we know that the lateral commissure is a little bit superior, and even though the red line showing the 0 degree of 4-chamber view, but as we advance the probe, actually the cutting plane moving to the medial segment. We can also manipulate the anti-flexion and retroflexion. If we do the anti-flexion, actually we are seeing the upward of the heart with the lateral structure more. If we do the retroflexion, which is quite usual maneuver we use to see the mitral valve, which will bring the probe and mitral valve and apex on axial. So just turn the big wheel counterclockwise rotated. So actually, another maneuver which has been mentioned in the JAS by the expert consensus, you can rotate the probe to right flexion. That with the small wheel turning the clockwise rotated, you can see from the panel A, you will bring the probe to the roof of the left atrium, which will make you more coaxial to the mitral valve. It's always the relationship between esophagus and the heart. So one way is you rotate the probe to the right flexion. Another way is you just let the heart to the left side, such as a tilting table, or just more aggressively, you can do the one-lung ventilation to bring to overcome very struggle situation. So we take this T imagery, for example, and we see the outer valve, we know a little bit too high, and we see too many right side structure. So how to overcome that? We have to advance a bit and counterclockwise rotation to see the left side structure, and we do some retroflexion, and we will bring the full chamber view we wanted. And the bicombination view, this is another example. We don't need to see the appendage, we don't need to see the left upper pulmonary vein, and we need to see medial segment more, so we had to advance and do the clockwise rotation to see the medial segment and do some retroflexion to bring the mitral valve on axial. So actually, is this a good image? Actually, we can do the grasping with this. I think it's a very acceptable imaging because you can see both the leaflet actually sitting on the clip arm. But we have to be careful that if we do the X-plane through that, not coaxial well, actually we are cutting the lateral segment of the P2. So on the right side, the P2 segment is not really sitting on the clip arm. So how to improve it? The concept is quite similar. We want to see the medial segment more, so we do more retroflex and advance the probe more. And now you can see by this maneuver, you can see the true sitting on the clip arm, the PML component. So the perfect image means you can see all the components at the same time, so that we will be very, very comfortable to do all the procedure. We take this imagery, for example, we see some artifact, but we see the leaflet, we see the clip. I noticed that some imager will say there are so many artifacts, not a good image. I have to do something, and they will rotate the angle and do some adjustment. But actually, from the implanter point of view, that is the perfect image because all the things is aligned, and you see the leaflet that is just above the clip arm. So it's a perfect image. I can deploy the clip. So my purpose is to do not be obsessed with the imagery other than procedure per se. From implanter perspective, how to avoid the shadowing? As we know that if we put the device inside the left atrium and the esophagus is seen from the behind, if we put a lot of guiding catheter, we do lots of maneuver, actually we also cause lots of shadowing. The anterior mitral leaflet, sometimes it will be obscured by the metallic shadowing. And actually it's a 2D plane, so it is not always, you can adjust the height, so the advance or withdraw the probe to get rid of the metal shadowing. From this imagery, you also know that the medial segment is always easy, prone to be obscured by the metal material. So let me go to the step-by-step. For the transeptal puncture, usually we use the bicaval view and find the tension. We do the X-plane, and we directly rotated the angle to 90 degrees. So that's the imager doesn't need to manipulate too much and do any retroflexion or anything else, and you can directly measure from here because it's a 0 degree. When you rotate the angle to 90 degrees, the X-plane will be a 0 degree. You can directly measure here. So how to deal with this kind of image for transeptal purpose? You know that you see the aortic valve again, so you have to advance the probe to get rid of the aorta, and you want to see the right interatrial septum, so you have to do the clockwise rotation. Why we have to do a clockwise rotation? From the MRI image, you will know that if you do the clockwise rotation, the interatrial septum will be clearly demonstrated. Sometimes you just can get rid of aorta, I think 160 degrees, which corresponding to the negative 20 degrees is helpful. And for the transeptal puncture, I think the imager must clearly demonstrate good tenting. Usually, the implanter will clockwise make the transeptal needle posteriorly. So you are doing the same thing because they are going posterior. You are also going to the posterior. So you have to go the clockwise rotation. So this is not a perfect image, and I don't remember the angle I use, but the most important thing is I show the transeptal side very clearly, so we can do the transeptal even in this terrible image. So there are many extrinsic factors which may affect in the transeptal puncture, especially for the imaging. That one of them is scoliosis, because the vertebral body will block the echo window directly seen from the behind, and also the dilated arterial root. For the perpendicularity check, I think the most important thing is you have to on-axis and make a 3D zoom with proper thickness. You avoid make it too big, and you will obscure your orientation and your real trajectory. And for this image, the implanter must adjust the artery hugging first, and then open the clip to check the perpendicularity first. And in all times, we use the aorta to orientate our mitral valve, but actually, as we know that the aorta is not always at 12 o'clock. So it will be wise to use the commissure. So you can see the lateral commissure very clear, and you can see the medial commissure. So that means you have to screw the ball to the right side. And the grasping is the most important thing, but grasping is happening before the leaflet insertion check. So we have to see the tip of the leaflet. So the most important thing is seeing the tip of the leaflet. Just like the right lower panel, you can see the leaflet actually is curved. So when you close the clip like this, your SLDA is happening. Because after you close the clip, you won't see the tip of the leaflet. So record everything. And there are some signs, just like previous Dr. Kang demonstrate that there's a significant gripper bouncing, so the tip of the leaflet must inside the clip. And we tend to directly see the leaflet inside the clip rather than do the minus job, because it is more convincing to see how much leaflet we have within the clip. So ladies and gentlemen, my summary will be keep 3D mitral valve in mind and do the retroflex, and also do some very important key step. Just for the imager, you must think like you are implanter. And as an implanter, you must know what image you would like to have. Thanks for your attention.
Thank you, Dr. Lee. I think we are behind the schedule, so we move to another lecture. Yeah. Takeshi Matsumoto, Shonan Kamakura General Hospital. He will talk beyond COAPT, shaping the future of the functional MR treatment. Dr. Matsumoto, please.
Okay, thank you very much. So this is my disclosure slide. So the COAPT trial is very important, and this trial made a very strong evidence of mitral TEER in the field of ventricular functional MR. So this is 2-year result. It showed a significant reduction of heart failure hospitalization and all-cause death. And when we look at number needed to treat, it's 3.1 for heart failure hospitalization, 5.9 for all-cause death. So it means, if we treat 3 patients, we can save 1 patient from heart failure hospitalization, and when we treat 6 patients, we can save 1 patient from all-cause death. And this is 5-year result. It also showed a significant reduction of a clinical event. And now when we look at current AHA-ACC guideline, to recommend class 2A indication for patient with GDMT and NYHA functional class 2 to 4 and ejection fraction 20 to 50 and LBESD equal or under 70 millimeter and PS systolic pressure under 70 millimeter. So it's those patients are enrolled in the COAPT trial, and now we can say this subset of patients. For this subset of patients, the mitral clip is mitral TEER is first-line treatment therapy. But at the same time, mitral FR trial was published almost same time as COAPT trial, but it didn't show significant reduction of clinical event. There are some reasons. The first one is severity of MR and LV remodeling. So baseline LV function is very low, and also in patient in mitral FR trial had a moderate MR in 50% of patients. And also the GDMT is not optimized before procedure, and the quality of procedure is not good in the mitral FR trial. But when we look at landmark analysis of mitral FR trial, this trial sub-analysis enrolled patients who survived 1 year without any heart failure hospitalization. And the primary endpoint was 1 year cumulative number of heart failure hospitalization. Here, not, so it is not statistically significant. There is clear difference in event of heart failure hospitalization. In device group, it showed low event. And also, this is a COAPT post-approved study. It is a prospective single-arm observational study, enrolled 5,000 patients in the United States. And it compared COAPT-like patient and mitral FR-like patient, and it showed similar and durable reduction of mitral regurgitation at 1 year and a large improvement in the quality of life in both groups. But when we see a number in of heart failure hospitalization, it's high in the mitral FR group. It's 28.7%. It may be due to baseline low ejection, low LV dysfunction. But now we can say that, so we can use a mitral clip G4, and now we know some tips and tricks of mitral TEER. So procedure is improving. So even in mitral FR-like patient, we can provide some clinical benefit. And how about moderate severity? So when we look at the TAVI field, there are 3 RCTs about moderate aortic stenosis. And this year, New York VALVES, one paper was presented at that conference. This is a sub-analysis of expanded study. It's evaluated clinical event in moderate MR group, and also this is moderate to severe or severe MR groups. So this is a main readout. It showed a significant reduction of MR in both group, and also showed significant LV reverse remodeling and symptom improvement by NOHA functional class and heart failure, number of heart failure hospitalization. But of course, we need RCT, same as a TAVI field. And final topic is acute functional MR in decompensated heart failure patient. This is 75 years old man who admitted to a hospital because of acute heart failure. And he presented with shortness of breath, NOHA functional class 3, and he had a history of ablation for atrial flutter, and he had a medication ACE inhibitor and MRA and beta blocker. This is baseline transthoracic echo. LV-DDDS was 6149 millimeter, and the ejection fraction, LV ejection fraction was 33.73%. It's reduced. And when we look at the mitral valve, there is a moderate to severe ventricular functional MR. The EROA was 0.29 centimeter square. But of course, first we started medication for acute heart failure. So SGLT2 was started and dobutamine was started, but it's very difficult to control, and patient was intubated and IABB was started, but we could not stop IABB. So this is transthoracic echo. On IABB on, then there is just trivial functional MR, but when we try to stop, this is 1 to 2, then MR became moderate or moderate to severe. Then when we stop IABP, it became severe. So we thought it is very difficult to control this patient, but the key, we thought the key is this dynamic functional MR. So we decided to perform mitral clip for this patient. The procedure was very straightforward. We deployed NTW clip in the little bit lateral side of A2P2 region. Then MR gone, just mild or trivial. Then day after procedure, IABB was stopped, and patient was extubated and discharged home after CRTD implantation. So this study is a retrospective study, enrolled a patient with acute setting MR following a mitral infarction. So when we compare medical therapy and intervention including surgery and also mitral TEER, patient in intervention group had higher prevalence of cardiogenic shock and use of IABP, but after treatment, patient in the intervention group showed a better survival benefit, better survival outcome. And again, when we compare surgery and mitral TEER, patient in TEER group had a higher prevalence of history of CABG and the low ejection fraction and high prevalence of cardiogenic shock at 52%. But again, a patient in mitral TEER group showed a better clinical survival outcome. But of course, this mitral TEER is very strong treatment option for this dynamic acute functional MR. It can provide an immediate reduction of mitral regurgitation with a very high safety profile. But difficult point is indication. When we should use mitral TEER and who need this procedure, it is very difficult. So it's case by case. So it's hard team discussion is very important for this subset of patient. And also, most of the case, GDMT is suboptimal before procedure. So after procedure, we should optimize GDMT, including a CRTD. So this is summary slide. So ventricular functional MR in patient with compensated patient. So current guideline recommend class 2A indication for patients who are enrolled in COAPT trial. So we can say it's for this subset of patients, mitral TEER is the first line treatment option. But even mitral patient who enrolled in mitral FR trial, so our quality of procedure is improving. Now we know typical tricks and also generation 4 devices are available, so we can provide some clinical benefit. And the moderate functional MR, of course, we need RCT for this subset of patient. And the ventricular functional MR in patient with a decompensated heart failure, so we can, mitral TEER is very strong treatment option. It can provide immediate reduction of the mitral regurgitation with very high safety profile. But the difficult point is indication, who need, and when we should perform. And also, GDMT should be optimized after procedure. Thank you very much.
Yeah, thank you, Dr. Matsumoto. So I think we have to continue the live demonstration. So during the live demonstration, is there any comments and questions?
So I think there is a good experience of patients with even papillary muscle rupture, etc. So that's where we have used TEER very successfully in bridging the patient to surgery. So that's another.
근데 두 번째 인설은 잘 됐는데?
Okay.
Yeah. So can you hear?
Oh yeah, we selected the XT and implanted it just medial to the first clip. And the clip insertion is good. However, you can see that the first clip is a little bit unstabilized with the second clip. Can you please show us the color?
Yeah, some MRZ, but
MR
it's
is
acceptable.
fine, yeah, and
You have to deploy here.
yeah, actually we have tried this is the second time, so we do not want to give more damage. So, do you agree to deploy
Yeah.
it here? Yeah. Okay.
How much is the gradient?
Can you please show us the gradient? 좀만 올려주세요. Gradient would be okay.
Yeah.
After the deploying first clip, it was 2, and now it is
3.
3. Yeah, gradient is not a problem. The problem is that the stability of the clip. That would be, yeah.
Yeah, we have to deploy right here. No more try.
Yeah. clip stable. 아래 요즘 지금 이대로 합시다. Okay. 1, 2, 3, 4, 5, 6, 7, 8. 제거하겠습니다.
Already done? Okay.
I deployed it.
Yeah, MR increase.
Yeah, MR is a little bit increased. Around the first clip.
No. Second clip.
Around the second clip. It may be related to the indentation or not. 그 혈압 조금만 봐주시고요. Blood pressure is a little bit high.
120, sorry.
130, yeah. It's increased.
Yeah, the alignment to clip is very good.
Yeah, where is the jet from?
Yeah, let me see. Between the clip maybe.
Between two clips.
Medial side.
Or the medial side.
Yeah.
Yeah, it's acceptable.
Maybe the
Minimum
indentation would be
London
touched.
MR.
Yeah. And there's some mild residual MR. Yeah. Okay. 파이널 에코를 한번 좀 이벨루에이션 해주십시오. Okay. Two clips are the places.
Yeah, the first clip is more stable than before.
Yeah.
After the
And some mild MR.
yeah, mild.
But
Yeah,
there's
it's
some a little bit mild jet from the indentation.
Yeah, let's check the pulmonary flow.
But the airway pressure is stable, still stable. And we are controlling the blood pressure.
Yeah, pulmonary flow was normalized. Pulmonary test wave compared with before the procedure,
Okay.
right upper press.
Because of the time limitation, I would finish our live case. For severe functional atrial MR, we implanted the two clips with the active W and the XT. And for the residual mild MR, with the low pressure gradient was a low pressure gradient. I believe that the patient has a severe orthosomnia before the procedure would be better this night. Yeah.
Thank you. Any comment? Any question? For this one?
No, I think it's a perfect result. Yeah, it's just a mild MR.
Mild MR,
Congratulations.
Yeah, that's good. Yeah, congratulations. Yeah, and thanks for sharing your live demonstration. And let's move on to another live demonstration from Japan. Shunsuke, can you hear me?
Yes.
Oh yeah. Can you introduce your team and your case?
Okay. Can you hear me?
Yeah, we can hear you.
Okay.
Yeah, go ahead.
Thank you, Jung-Sun. So first of all, it's my great pleasure to have a live case demonstration in AP valve this year from our Kurashiki Central Hospital. I'm Shunsuke Kubo. First operator. The second operator is Kohei Osakada. And third operator is Dr. Mushiake. And the fourth and fifth is standing below Dr. Nishiura and Dr. Fujita. Echo cardiographer is Dr. Maruo. And we have Dr. Harada. And the anesthesiologist is Dr. Ishida, who is the chief of our anesthesiology department. And also we have Dr. Miyamoto, he's a resident. So let me introduce today's case. Okay?
Yeah.
Okay.
Good afternoon, everyone. My name is Kohei Osakada in Kurashiki Central Hospital. I want to start the presentation. Our case is a 78-year-old female, and her NYHA class was 3, and clinical frailty scale was 3, and her SS mortality score was 16.7%. She has a history of previous MI, and she underwent PCI from LMT to LAD using cipher stent. And also, she has a history of LP thrombus, and she's taking warfarin. And other conditions include pulmonary tuberculosis, retroperitoneal fibrosis, diabetes mellitus, lung cancer, and colon cancer. Next slide, please. This slide shows her medication and examination findings. She is receiving almost optimal medical therapy, including furosemide, tolvaptan, eplerenone, dapagliflozin, carvedilol, and warfarin, and so on. Her vital sign is blood pressure 86/56 mm mercury, and pulse rate 75 beats per minute. And blood test shows elevated creatinine level and PNP level. And there are no anemia. ECG shows sinus freeze and wide QR duration 133 milliseconds. Chest X-ray shows cardiomegaly and no congestion. Pulmonary function test shows mild obstructive respiratory impairment. Next slide, please. TTE shows severe LV dysfunction due to ischemic cardiomyopathy and severe ventricular FMR. Her MVA was 4.91 square centimeter. I think it's enough to perform TER. Next slide, please. This slide shows TE images. We can see the wide regurgitant jet from A2P2, mainly from major A2P2 part. After the presentation, Dr. Maruo will review today's findings. Next slide, please. And now I want to show our strategy. We planned to perform septal puncture in mid-posterior position. Planned device was Mitral clip G4XCW. Our target is major A2P2. And our teaching point was described as below. First, how to optimize the device trajectory in the left atrium. Second, optimal clip selection and position in ventricular FMR. And finally, understand the endpoint of GR using mitral clip G4. Thank you for your attention.
Thank you, Dr. Osakada. So today's case is, I think, a typical ventricular functional MR. And I think that this anatomical findings met the COAPT criteria, as Takashi presented the previous lecture. So please discuss about this patient and echo findings and clip procedure strategy.
Yeah, go ahead.
Hello, Kubo Sensei. This is Naganuma from New Tokyo Hospital speaking. Good luck for case procedure. My question is a general one. So echo showed pulmonary hypertension at the procedure. So do you stand by ASD closure just in case of right to left ASD shunt after the procedure?
Thank you, Naganuma Sensei. In these patients, actually, there is some pulmonary hypertension, but right heart function is very good, and also now we can see the CVP in from the CV line. The CVP is now only the 5 mm mercury.
5,
and,
okay.
Yes, and after the guide inserting the guide catheter. Left atrial pressure is like this. Mean pressure is 35 and V wave is 52. So I think that there is no risk of the right to left shunt.
Oh,
but
I see.
I think that I think that the shunt from right to left to right shunt is there is some risk of the right heart failure, but I think that there is no right ventricular dysfunction, so I think there is no risk of the shunt-related complication.
Okay, thank you very much.
So proceed your procedure. So I think we have 30 minutes for the live demonstration.
3 minutes?
30 minutes.
Sorry. 30 minutes. Okay.
Yeah,
30 minutes. Okay.
Yeah.
Not so 3. I already. Yeah.
You can do that? 3 minutes within 3 minutes.
If you do it in 3 minutes, we'll have a good time. So maybe discuss the clip choice, and then you can continue to work, and we can discuss some of the points.
Yes. So first of all, we already punctured the right femoral vein and inserted guide catheter. So Dr. Maruo will show you the today's echo and also the today's puncture site.
Thank you. So I'd like to show you the today's images by TE. This is the X-ray image, and you can see it's under P2 tethering, and the etiology of MR must be the ventricular FMR. And here is the target point, medial P2, I guess. So
Can you show us septum?
Yes.
Yeah.
Septum. Do you want to see septum? Yes, I see. Understand. Do you want septal puncture?
More puncture.
Yes, I see. Okay.
So we puncture the here, so mid and posterior.
Yeah, mid posterior.
But as you can see, the distance from the anterior to the posterior is a little bit narrow in this patient. But we can get the height. 高さで言ってもらっていいですか? Height like this. So from the tenting to annulus is 33, and tenting to the tip of the leaflet is 40. So I think this is a typical septal puncture height of the ventricular functional MR in the Asian and Japanese patients.
Yeah, looks good. Yeah.
Yeah, let's go. So let me start my procedure, okay?
Yeah.
Yep, please go ahead.
Okay. じゃあ先生行きましょうか。はい、OK です。
Most of panelists agree to use XTW in this case.
Okay.
Yes, I think this is for the jet. Although it's a functional MR, the jet seems to be quite local at one point. Usually we see for our functional MR with a wide gap, but luckily this case the leaflet length is quite good, especially for the anterior leaflets. The posterior has some tethering, but actually it compensates by pushing it a little bit upper. So I think XTW works well in this case.
XTW, yeah. All agree. Go ahead.
So I have one question. Dr. Osakada mentioned you deploy the clip in the medial side. So you mean this is something like a heterogeneous functional MR, right? So in such case, how do you decide the deployment point? It depends on the biggest gap or the biggest pizza.
I think the gap is the most important important findings, because the concept of the mitral clip is to create a new coaptation line by the implantation of the clip. So that's why I usually put the clip in the most non-coaptation point. Yes.
I think for 3D imaging, it shows the tethering is mainly at that point, and so probably we can assess that a bit just before the clip deployment.
弁管とかちょっと上げておきましょう。
やっぱりちょっと。So as you can see, there's a little bit out hugging. So we put the platinum like that. そうだね。Still the medial right, so we off the medial.
Medial type.
先生ちょっとプローブ引いてもらっていいですか？ストラドルちょっとチェックして。So we check the straddle. So is the over straddle? 戻っていただいて大丈夫です。How about the trajectory?
Good. How much do you apply a plasma? And is there any some?
It's a 75 degree. Not so many. So I think maybe ML trajectory is very nice. So how about the LVOT? I think we need a little bit more plus, right? Do you agree?
Yes, I agree.
So Dr. Kubo, I have a question. There is a dense corridor from the medial side.
Yes.
Do you go for more medial from this cord or lateral?
I think that you can see some cord in the medial side. I think that we can see the 2 or 3 cord, right? So I will put this clip at just most lateral cord in the to the medial position.
Yes.
Right.
So, Maruo先生、矢印。
Yes. I think here is the code.
Yeah, here is the code. So yes. I think optimal, clip position is here.
Yeah, I totally agree.
This code here.
Yeah, just next to the code.
Yes.
I think so, yeah. That's the first case. And even then,
so,
yesterday's case.
ちょっとまたオーバーストラドルになっちゃった。This is just over straddle, so we adjust the throttle like that. And how about LVOT trajectory? We need more plus.
I think it's okay because there's
Okay.
a tether PML. Is that a little bit tether? So I think it's.
So I think the trajectory, the checking trajectory should be adjusted like this, so around the bar. Do you agree with that? どう？まあでもいいんじゃないかな、ここで。こんなもんで。So we open the clip, right?
Yes, R3D zoom, 3D zoom.
ちょっとずれてるね。
So Dr. Kubo, the clip is very stable, looks stable in by commercial view.
3D zoom.
So
Yes.
did you reduce tidal volume?
Yes, I think that, yes, tidal volume 下げていただきます。Yes, already reduced the tidal volume, so I think that 350 or something, yeah. So we have to turn clockwise.
Yes, clockwise, yes.
So is there any recommended tidal volume during the grasping, or just
I think
depends on the patient?
usually around between the 300 and 400, because if the tidal volume reduces too much, so end tidal CO2 is increasing, and the pressure is also increasing, and it is difficult to grasp. So I recommend the tidal volume around 300 to 400.
Just during the grasping, or just all procedure?
Just grasping, and after inserting the CDS in the left atrium. 2D 戻ってもらっていいですか？もう一回閉めますね。
So as Dr. Naganuma mentioned, and hypercarbia is also the risk for the iatrogenic ASD issue, because hypercarbia make pressure pH higher.
大丈夫ですね、大丈夫ですね。そこにあるですね。
Yeah, sometimes when we reduce the tidal volume, we can compensate by the increasing rate of respiration as well.
ちょっと M か。
Usually it's just at the time of grasping, so usually it doesn't affect that.
Just 2 or 3 minutes.
Yes.
ちょっと M かな。
でも先生、バイコミッションも若干 M なんで、
そうね。
これでいきますか。
これでいきますか。
じゃあ開けますね。So the trajectory that looks good, I check the perpendicularity again in the 3D image. So a little bit more clockwise. Like that. But I think the clip turn more clockwise if the fan we inserted the clip to the left ventricle. So I stayed here and checked the gripper.
横にずらす。
My anterior and posterior. じゃあこっちが前ですね。And I already I also checked the perpendicularity in the fluoroscopy. じゃあフローか先生。言うてもね、これちょっとあれなんだけどね。そうなんだけどね。頭だね。もうちょっと。もうちょっと。Okay, so this is a little bit LAO and cranial. So this is a perpendicular image of the mitral valve in this patient. So, so close the clip and I will insert the left ventricle.
カラー見る。
じゃあ一回見ますか。
Yes, Dr. Kubo, you demonstrate very nicely about the use the fluoroscopy to remove the parallax.
Yeah,
but usually we do it when the clip is still closed. So you do it by after opening the clip, or?
Yeah.
Okay.
It's quite
変化の件数。
William. Oh, hello.
guidance.
Okay, so insert the clip to the left ventricle. ついていきますね。どうですか？
ちょっと右ダイブ。
まあでもいいかな。
まあいいか。
カラー入れてもらっていいですか？So we usually check the color here. まあいいですかね。いいですね。And insert the LB. ああ、カラーも。
光線ね。あ、入ったかも。だね。
じゃあ 3D ください。はい。Orientation is a little bit counterclockwise.
Yes.
So we little bit clockwise.
Yes.
Okay.
ちょっと減速したけど。
じゃあ、
いいですかね。
The 3D looks good, so I try to grasp the leaflet. But
ちょっと斜めにするか。はいか。ここに行こうか、とりあえず。Yes, 乗ったね。じゃあちょっと引くんで。So,
how about the leaflet insertion? Anterior is looks good, and also we have to check the posterior leaflet. Little bit.
Yes.
もうちょっと欲しい。
I'd like to grasp more, a little bit more.
So Dr. Maruo recommend to catch the posterior leaflet more, little bit more. So we turn the guide little bit clockwise, and check the 3D image.
Yes. ちょっとカウンタークロック
でもね、もしかしたら検索があるかもしれない、そこ。じゃあちょっと 2D 戻ってください。どうですか？
インサーションいいですね。はい。光線がね、今。
How about the insertion? I think that the insertion is good. Both are good.
Yeah, very good.
Yes, it looks
and
better than before.
Orientation is also good. And check the position by color. The color. I think this is position is the ideal position.
Yes, ideal. Yes.
じゃあグリッパーいきますか。じゃあ
ちょっと斜めで。
どうですかね、光線は。
I think this is a very nice and beautiful image. Yeah, you can see the
山口
tip
さん
of
光
the
線をつけた
leaflet.
と思う？Okay.
Yes, and you can also see the gripper. So all the things is showing clearly.
どうですか？
いいですかね。
あ、いいですね。So 3D もらえますか？
はい、3D。
So always we check the 3D image before the closing the clip.
ちょっとカウンタークロックワイズ。
A little bit counter, but I think that this is acceptable. So I will close the clip.
Yes, I agree. Yes.
先生、どうしようか。
はい、じゃあ explain。
いいよ。じゃあ閉じて。
はい。ちょっとだけ。
いいよ、閉めて。もっとちょっと待って。オッケーオッケー。ゆっくりゆっくり。うん、いいよ。うん。ちょっと待ってね。でもうちょっといこうか。
いいですね。
で、かから入れようか。
うん。
あばでも、
いい気がする。
we can see a little bit residual jet it's medial to this clip. But I think that this is indentation jet. Yeah, here. How about the digital jet?
Dr. Kubo, my name is
Yes.
Shirai. Thank you.
Shirai sensei.
Yeah, so I think the lateral side is indentation, I think, but the medial side is some pitch grip and it's pitch jet is what is seen. But according to the small MVA, I think it is impossible to place another clip, I think.
Yes, I agree. So 3D 見ますか。So check the 3D image.
I think it's very important once you close the clip and you see some jet and to review back about the pre-procedure imaging, if there is any indentation, pre-existing flow convergence. If there is already existing, then everything is fine. But if before the procedure, if the indentation does not have any this kind of image about what of my concern is about the orientation.
Yeah, orientation. Yeah.
It's just actually it's very very close, but just a bit difference. I don't know if that is maybe maybe it's just a pre-existing indentation jet. Yeah. So it will be better to review the pre-procedure imaging.
Yeah, I think that this medial jet is a little bit increased by putting a clip. But as you can see, we advancing the clip LV too much because I usually advancing the clip to the LV during the closing the clip to avoid the reflect injury. So that's why this indentation jet usually increase a little bit. But so here is I said this medial jet is very far from the this clip.
Yes, I agree. The medial jet and lateral jet is very distant from clip, so we don't need to chase it. But there is tiny clip through jet, right?
Yes.
Yeah. Maybe due to clip orientation, but I feel it's just minor problem. So maybe we can leave it.
Yeah, I agree with Takashi because you can see there is too much tension both anterior and the posterior reflector by closing the clip. And also this is not full closing, so we can close more. So, but I think that we can leave this jet, so we continue to close the clip. こうか先生。もうちょっと締めますね。はいはいはい。もうちょっといける？
So in this case, it's better to close now or just to change some orientation, perpendicularity.
Yeah, I think I don't need to change the orientation because this is flow close. Because we can see some code in the posterior reflex. So I think that if there's a code in the posterior reflex, we never go to the correct perpendicularity because there is a code. So we cannot put the posterior reflex with code. So I think that this position is optimal, and MR I think that definitely reduce it, and the digital jet is very far from the this clip. So I think that we can release this MR jet.
So what's the degree of residual MR at present? Because MR is reduced, but what's the degree? Is it still moderate MR?
It looks mild to moderate MR, but I expect the MR will decrease after deployment.
I think this is a mild remarks on the. We check the some parameters. So the 3D and 3D image, 3D color, and the permeable flow, and the mean gradient.
So one of the lessons from surgery is, when we repair valves sometimes with cords and you try and correct the primary jet wherever that is, it sometimes leads to traction on other segments. And that leads to malcooptation, especially if the posterior leaflet height becomes shorter. So worth checking that before releasing, I think. And it's not necessarily always 3D clefts. So it's usually the P2 or whichever, in this case probably P3. But you will get more leak suddenly from an area there was no leak before. So this is not uncommon in surgery sometimes.
じゃあ一通りチェックして、その P3 のところをちょっと見てもらっていいですか。
じゃあ PV いきますね、とりあえず。
So we check the PV flow and the PV flow, the PV flow is a blunted pattern.
Blunted pattern, yeah.
So, but we can see the systolic dominant. It's normal.
So what about the blood pressure? Is it improved after the clipping?
Yes, I think that about a 10 millimeter mercury increase.
Yeah, Kubo, I think we have sometimes experience to release after releasing the clip, the tension is released, and sometimes the mitral regurgitation is gone. I think this is another possible explanation.
Yeah, of course, I expected that.
Yeah. Otherwise, I think it's some different. I think malorientation cause sometimes malcooptation in another segment. This is another possible cause to increase MR. So I think we can think about that.
Yeah, but so we check the 3D image. 3D ちょっとチェックしましょうか。
Mean pressure gradient is 3.
Now the mean pressure gradient is 3?
3, yes.
And sometimes because the CDS is connected at an angle, so you get slightly aortic hugger, it will tilt a little bit since the tension. So.
How about the orientation? I think orientation is not so bad. ちょっとゲイン下げましょうか。Check the orientation by reducing the gain. So I think that orientation is not so bad. And check color 入れます。Color. So I think that this indentation between the P1 and P2. And also here is a little bit, anterior leaflet is a little bit short. That's why, this jet is difficult to be erased.
So in this case, medial tethering is so strong, as you see. In such case, this residual MR would be acceptable for me. Yeah, it happens. I think this is the best result in this anatomy.
ちょっとメディアルちょっと見てみますか、2D で。So we check the medial jet by 2D and 2D color. Yeah, here, I think the jet origin is, this actually this is indentation because we can see the just lateral to the P3 segment. Yeah. So I think that we can release the clip.
Yes.
Yeah. Go ahead.
Please go ahead.
じゃあリリースしましょうか。トライアルオープンしますね。
カラー入れますか。
じゃあ。どうですか。カラー抜いてもらっていいですか。はい。カラー入れてもいいですか。大丈夫かな。光線がなんかちょっと押してるかな。ティアしてません？
Dr. Kubo?
Yes.
I'm Williams from Taiwan, and maybe another approach is to do just 12 to 6 o'clock, just at the center of the
yes.
A2P2.
So you can see the
Yes.
jet from the jet just posterior to the clip. So I think that there is some tear of the leaflet. So I did check the position and leaflet.
じゃあちょっと外しますか。一回引き上げますか。
はい、OK です。カラー入れてもらっていいですか。はい。延長はしなくていいんやけどな。So you can see some residual MR very posterior. So we have to grasp the posterior leaflet more deeply. いや、もうどうしようかな。一回帰りますか。よいしょ。はい、戻れたかな。じゃあカラー入れましょうか。あんまりしゃっきりしないね。はっきりしないね。
While the team is doing that, I'm just curious because in Asia, usually you see low BMI patients. We don't see these patients. Less than 150 height, less than 50 kilo.
But now,
do you think the tissue characteristic is different as well? Like leaflets are fragile?
I think so.
Yeah, a lot of MR.
So there is some emergent mid portion of the posterior leaflet.
関係ないけどな。
いや、まあテンションなんでしょうね。So I will.
Let's look at the 3D. There may be a torn core. Oh, it's a white jet now.
まあ先生、じゃあこれを真ん中に置いて、いや、これを真ん中に置いて、あそこがあんまり出ないんやったらそれ放置でもいいかなと思ってる。
T もありか。
いや、でもそこダメでしょ。そこは置けないんで。
じゃあラテラール。
ちょっと真ん中に
行きますか。
So I think that we scared to put the clip in the perforated part. So I put this clip in the central A2P2.
Yes, I totally agree.
Yeah, here.
Yes.
Yeah, プラスあったら逆に。
そうですね。
カラー言ってもらっていいですか。そうだね。 もうちょっと行きたいね、後ろ。
ちょっと検索が。入ったね。
Yes, perfect.
How about
Yes, perfect.
here? カラー入れてもらっていいですか？
はい。まあ、
ティアはどこですかね？あそこだ。そうだね、もうちょっとラテの方がいいかな。それで3D もらっていいですか？もうなんか検索があって入らなさそうだね。same position。そう。じゃあちょっと戻ってもらっていいですか？3D ください。オリエンテーションをしっかり合わせにいるのか。じゃあ戻ってください。いや、もう言ったよ、今。これがあるの。ちょっとラテン入りました。カラー入れて。It's definitely more lateral to the first position.
ティアだね。
ここがティア。
Here is a tier.
Yeah.
Yes. じゃあ3D 見ますか。Orientation is quite good.
Yeah, perfect orientation.
Yeah.
じゃあ行きます。
じゃあ戻って。
Do you increase the peep, which may?
Yeah, no. Not change it.
They can take their time.
構成もいいですかね、先生。
あんまり深くいかなくてもいいですよね。
Yeah, perfect.
Perfect? Check the 3D.
Yes.
Orientation is good?
Yes.
Okay. カラー入れてもらっていいですか？なんか、まあ減ったかな。じゃあ戻ってください。
カラー入れましょう。
So I think that MR is much better than previous one.
Yes, sir.
It's very true. So,
Yes, here, but not so MR not so big. Yes.
The tear is
So
just very, very small, very tiny.
Yes.
And you fix the most important part.
Here.
The location of this clip is okay, I think.
And the orientation is perfect.
Yeah. And consider one more clip to media side.
Yes.
you can grasp more longer lengths of posterior reflex. So you can, I feel you can grasp the tiered region. You can cross it.
Yes, actually, after this clip, you will bring the tear part.
Hello.
I think, Dr. Kubo, in interest of time, if we can just look at the COAPT assessment before we
Yes.
move on to the next. Thank you.
I think this is just a little bit closing, but as you can see that there is no MR around the clip. And there is a tiny MR jet in the medial to the clip. But in the perforated part, there is very small pizza here, like that. So I think we leave this medial jet.
Absolutely. Yep.
Yeah.
Great. I think, thank you very much. We are going to sign off here. So again, thank you for.
Thank you.
Thank you.
Very good demonstration. So I'm just going to summarize the session quickly before we move on to the next session. So we saw that the indications for TEER are increasing now. They're not just FMR, but multiple other indications. We have 4 clip choices now, which we can use. We also saw how important imaging is. I think the imagers need to understand what the procedure is, and the proceduralists should understand the imaging as well. And again, 2 great cases, very different pathologies, both challenging, I would say, and the teams did really well. And thank you to all the panelists as well as my co-chair for the input. Thank you, and have a great evening.
Thank you.